A very good evening to one and all. I have chosen vertigo because vertigo is the most common complaint encountered in the primary care as well as in the emergency setting. So typically what is vertigo? Vertigo is the false sensation of motion. When the motion is, when it is not true, the person perceives as there is some motion is going on. So that is a false sensation of motion, typically the rotational, and it is resulting from the vestibular dysfunction. Yeah, coming to this, can we answer this? Like, is this vertigo? So as we discussed, it is a false sensation of motion. So here there is a true motion going on. So this we cannot call it as vertigo. But yes, this dog will have vertigo once he stops spinning. Okay, so there is usually what we call as vertigo is a patient comes to OPD and he'll tell chakkar aata hai, kallu tirugutunai. This is the most common complaint we hear. So that kallu tirugutunai can be anything. So coming to vertigo is one type of kallu tirugutundi. So this vertigo, the typically he says is rotational sensation, like when how fan is rotating, like that whole room is rotating around myself. This is the most common complaint. Then only you will call it as vertigo. There are another types of vertigo, that is non-spinning vertigo. The patient can feel like some leaning type of sensation or some swaying type of sensation or sliding or even the bobbing sensation. All this also we consider it as vertigo. But most common thing is the spinning sensation. Though what is the common thing here? There is some false sensation of motion. Along with that there is impaired spatial orientation. That we call it as vertigo. So what is not vertigo? So impending syncope or impending faint, that also they call it as tal tirugutundi. The tal tirugutundi can be detachment from the reality, disordered thinking, or this weakness, non-specific malaise or imbalance. All this they call it as tal tirugutundi. It is our job to differentiate whether it is vertigo or not, because vertigo will be treated with some drugs, whereas all this cannot be treated with those kind of drugs. Okay, so we have this classical paper, 1972 published, which holds good even today. This is a Dutchman heart classification. What they have classified? They classified this dizziness, that is a tal tirugutundi, into four main things. One is syncope, near syncope. Other thing is disequilibrium or the imbalance. And the third one is vertigo and some psychiatric. That psychiatric thing also they can complain as dizziness. So coming to each, pre-syncope is essentially the cardiovascular problem. So any low cardiac output or any vasovagal, postural hypotension, all this usually they'll cause impending faint, pre-syncope. So this will be either in the upright position or in the when they get up from the supine position, or from prolonged sitting. If they get up, then they might feel this dizzy. So this history is very important. So tal tirugutundi means we have to go in what do you really mean by tal tirugutundi and all. Okay, then vertigo we'll discuss in detail. So we'll come to the other variety of dizziness, that is a feeling of imbalance. This unsteadiness, feeling of imbalance, this occurs usually only in the standing and walking. So supine sitting position, they won't feel dizzy. And this will be increased when walking on the uneven ground or in the darkness, or when turning I feel more dizzy. So this is when you come across this imbalance, you will have the n number of neurological causes for this imbalance. So it can be from the higher order neuron, the parietal lobe, gait apraxia too. It can be basal ganglia involvement, extrapyramidal or cerebellar, or there is a myelopathy, neuropathy. All this will cause imbalance. But this patient will not have dizziness while sitting. This is only while walking or during the nights or when turning around. So psychiatric thing which will not fit into any other three things, and they'll tell very vaguely complaints, lightness, lightheadedness or heavy-headedness, tala dimmuga undi, all this we cannot classify into any other thing. Poor history will be there. So we have an approach to vertigo or dizziness. We have a titrate approach, timing, triggers and the targeted examination. So timing can be, is it episodic or continuous is the first question when they come to us. Is it episodic? If it is episodic, are there any triggers, or is it spontaneously coming? So triggers will be there when, in case of BPPV, if you put the head in some position, then you can have some triggers. So you can have dizziness. So that we call it as trigger. Or in case of postural hypotension also, only on getting up from the supine position or on prolonged sitting to standing position, we can have dizziness. That also we call it as some trigger is there. Or if is it spontaneous? If it is spontaneous, episodic, then you should ask other histories like is there any headache, like vestibular migraines can present with vertigo and headaches, and is there any hearing loss? Then vestibular neuritis, Meniere's disease can also present with vertigo. Then or are there any dangerous Ds, the dysarthria, diplopia, etc. All this will cause also vertigo, that is secondary to the brainstem dysfunction. So is it continuous also, we should see. If it is continuous, is there any inciting event like any head injury? After that he started developing vertigo, which is continuous. Or is there any drug or toxin he got exposed to that, after that he developed vertigo? Or is it spontaneous? Usually the stroke, TIAs, all this, they will have spontaneous onset. So this is like central causes only we should think of stroke. Anything affecting the brainstem can cause vertigo. So it can be infection or any tumor or stroke. Whereas coming to the peripheral, most commonly what we see is BPPV, vestibular neuronitis, Meniere's. So this history will go to one patient. What he says, we'll listen. This is like patient himself is telling the diagnosis. He is telling that चक्कर आता है, he is feeling dizzy. And when are you feeling dizzy?
क्या करता है?
When getting up and when you sleep also supine position, when you turn to this side, when you turn to that side also you feel chakra. How much time it will last? 2 seconds. So this is the typical history of BPPV. Whenever he says vertigo, I mean chakkar aati hai, even in the supine position you have, we should ask, then is it on turning to either side of bed also you are feeling dizzy? That is the typical history of BPPV. So unless we confirm that as BPPV, we won't do further things like this is a typical history, so we have to confirm that even in the examination. So first thing, how can we confirm? We have to elicit the nystagmus in the OPD. So how are we eliciting the nystagmus? Easiest thing is requesting the patient. So he gets vertigo in some position. So that position he will be avoiding since months and years. So we can ask the patient, can you be in that position so that we want to see the nystagmus. So he will, then we can see like when we request the patient, he can take that position. When the patient takes that position, we can see here, there is we can see the nystagmus there. There is a vertical torsional nystagmus. Can we see that? There is some rotational movement also along with vertical movement. So if we don't get nystagmus on requesting the patient, next thing what we will do? We can do Dix-Hallpike maneuver. Okay, so Dix-Hallpike maneuver we all know. It is turning the patient head to 45 degrees to one side and making the patient lie on the bed, hanging the head. Make sure that we will not injure the cervical spine. And here in the Dix-Hallpike, when the affected ear is downward, we can see the nystagmus beating upwards. That is a upward beating nystagmus when the diseased ear is on lower side. Okay, so other thing is in OPDs this head position and all we might not keep because there is a less space and all. Sometimes we have a bed attaching to the wall. We can do even the side lying test where the head is supported on the table itself. Same the Dix-Hallpike maneuver. So in Dix-Hallpike maneuver, we'll see the upward nystagmus when the affected ear is downwards. So this is for posterior semicircular canal. So we have anterior, posterior and lateral semicircular canal. If posterior semicircular canal is affected, we can see nystagmus in these two tests. If lateral is affected, we should do the rollover maneuver. Rollover maneuver. So we'll ask the patient to roll over on the bed to the affected side. Then we can see the nystagmus. This is the lateral, horizontal nystagmus beating laterally. Then what we do, once it is BPPV confirmed, we have to reposition the patient. That is the Epley's maneuver that we have to do. And we have to advise the patient some exercises. So what we ask to do for BPPV patients, we have brand arrow of exercises. These things we do for BPPV patients. So here, same like Dick's Halpipe maneuver, we'll we'll ask the patient to keep the neck to 45 degrees, lie on one side, 30 seconds, 1 minute, 30 seconds to 1 minute, then again midline, then again to the opposite side. So this, as a cycle, you should do 5 times, and each cycle 3 times a day. So another case will go. So we have seen BPPV. What is BPPV? He'll typically tell rotational nystagmus, rotational feeling around, rotational feeling, whole the room is revolving around himself. Then even on sleeping he'll get, on supine position, even on turning to supine position, that side, this side, he will feel dizzy. And on examination we see there is a nystagmus elstrable by Dick's Halpipe. Then we have to correct reposition, and we'll give the brand arrow of exercises and we'll send the patient. So once we reposition the patient, usually patient should not require any vestibular suppressant. If patient is requiring vestibular suppressant even after repositioning, that means repositioning is not very successful. Okay, so next patient, male with positional vertigo. He is a male with positional vertigo, like 30 to 35 years old. Then he has brief attacks of positional vertigo since 2 months. Along with that, he has even 5 months history of weight loss and anorexia, and he was done repositioning maneuver elsewhere by other neurologists, and after that he was kept on vestibular suppressant and sent home. So this is the thing, when repositioning is done, usually we won't put him on vestibular suppressant if it is successful. So here itself we got some two red flags. Okay, so 2 weeks later he developed diplopia. So here what can we see? There is a nystagmus, can we see? So there is a nystagmus. When you see to the left, there is left beating, and when you see to the right, there is right beating nystagmus. So when you are looking up, even there is a little upward component, and when you see to the left, so this typically we call it as gaze evoked nystagmus. When you see to left, it is beating left. When you see to right, it is beating right. Whereas in case of BPPV, it will be unidirectional. To the affected ear, it will be beating. Okay, so even if you turn to other side also, it will be beating to only one direction. So this is one more red flag. So this patient had something centrally, and when we did imaging, it showed multiple tuberculomas in the brain. One is exactly sitting on the fourth ventricle, the ring enhancing lesion. So that is the history. When history is pointing to us. So positional vertigo is there. Unless you confirm it with Dick's Halpipe, you should not think it as BPPV, and even the repositioning was not successful in that patient. Along with that, you have some red flags like weight loss and anorexia. Next patient, same history like BPPV. So BPPV is the most common, so I'm coming along, who can come with BPPV, but it is not BPPV. Okay, so this patient also has same history like BPPV, then clinically no abnormality detected, and Dick's Halpipe is negative. So at that time, we should not, what we should do, we should try to reposition. If repositioning, immediate relief, then that is fine, we can close the patient there. If there is no relief with the repositioning, please do not give drugs, please do imaging. So this patient, imaging showed there is some tumor in the fourth ventricle, okay, ependymoma. This is 82-year-old diabetic hypertensive patient who came with acute onset dizziness. So anything in neurology which is acute, you have to think of stroke. That is the first thing, whatever it is, neurological deficit or diplopia, whatever it is, weakness. So here acute onset dizziness. But what is happening here? BP is normal. This is tricky. Then speech is normal. Usually central cause of vertigo, what will be there? Diplopia, dysarthria and all will tell no. So all that is not there in this patient when he came to us. Then there is but some vertigo nystagmus and some mild instability in the gait. So on examination, this patient had vertical nystagmus.
ओके, ऊपर देखो, यहाँ देखो मेरा उंगली.
Okay, that is a vertical nystagmus. So whatever gaze you are seeing, it is a vertical nystagmus. So this patient came with 2 MRIs. Old MRI is there, which is showing some ischemic, non-specific small vessel ischemic changes. And after 48 hours, he went to another neurologist, and that is also showing no infarct. And we have repeated an MRI after 72 hours, which showed a lacunar infarct in the pontomedullary junction. So here what is the take home? In this case, anything acute, please don't take light. And BP is normal. Usually a stroke will have BP high, but if he is on antihypertensive, so BP can be normal sometimes. And MRI can miss acute lacunar infarcts till 72 hours. So whenever you are suspecting clinically, please admit the patient, treat it as stroke and repeat MRI after 72 hours. One more case. So young boy with recurrent brief vertigos. This is 3 days ago with mild vertigo and without tinnitus or deafness, no other ear complaints. He went to general practitioner and he was kept on anti-vertigo drugs combo. Here what can you see? There is, very good. There is a nystagmus even in the primary gaze, okay? Usually the ear complaint and all, end gaze only you will have. So primary gaze, nystagmus is there. Please do not take it light. That is also abnormal, okay? In the primary gaze itself, you can see the nystagmus, left beating nystagmus, and on examination, this is what examination? Finger nose test for cerebellar lesion. So what are we seeing here? So left is normal, right? There is dysmetria, okay? So young patients, no need, shouldn't think like no risk of stroke and all. This patient had protein S deficiency on evaluation. He had a midbrain infarct, thrombophilia condition. Okay, we have one more young boy, 1 month unsteadiness while walking. And you can see the so nystagmus to right side when you ask the patient to look right, and when you ask the patient to look left, there is nystagmus to so left side. So again it is gaze evoked nystagmus, so we shouldn't take light. It is not unidirectional. So this patient has showed pontine glioma. He was given anti-vertigo drugs since last 1 month. He was roaming here and there. Then finally when imaging showed there is a pontine glioma. Okay. So next there is coming to last, this is a case who came to me when I was working in ashram. There was a 55-year-old man who came with dizziness and he is a known hypertensive. This dizziness was preceded by 3 days loose stools. Then he went to GP, he was prescribed, same thing he told, taltirutundi, and he was kept on anti-vertigo drugs, and he used anti-vertigo drugs for 1 week and no improvement. Along with that he was feeling very drowsy with all the drugs. Then he came to me. Then what happened? So it is our responsibility to know further history. So he was feeling dizzy only on getting up from supine position, and supine BP was 130, standing BP was 100. There is almost like 30 fall, and along with that he was on Telma H and loose stools history. So it is like postural hypotension which is causing dizziness. It's not vertigo or central or peripheral. So what did I do? Gave oral fluids along with that plenty of fluids, rest, postural measures, and removed H. I continued him on Telma. After that he was fine. So only one topic, this is like already the next topic is covering pregnancy. So I thought all will be with gynecologist. So vertigo in pregnancy, as any other organ will have structural functional changes in pregnancy, even the audio vestibular system also will have some changes in pregnancy due to hormonal changes, as well as there is even low osmolarity, low blood pressure, which can make patient feel dizzy. So even the pregnancy, even the obstetricians can encounter vertigo commonly in their pregnant females. So usually what we do, we'll give some dietary advices like oral fluids, increase, and then avoid caffeine and all. If it is BPPV, we have seen BPPV how it presents. So BPPV, then repositioning is safe in pregnancy, and vestibular exercises we advise. Only if necessary, go with drugs. The dimenhydramine and meclizine is safe. So what is take home here? Every dizziness is not vertigo, and vertigo can be dangerous sometimes when brainstem is getting involved, and vertigo is very treatable if correct diagnosis is made. And for BPPV, learn to reposition and do not miss stroke in first time vertigo. Thank you.